Good evening. My name is Jessica Roman, and I hold the distinct pleasure of acting as Program Manager for the incredible Center for Digestive Health team here at Virginia Mason Franciscan Health. It is my pleasure to welcome you to tonight's lecture. We host a lecture series yearly on a host of topics of digestive concerns. The Center for Digestive Health is comprised of a team of pathologists, gastroenterologists, surgeons, oncologists, endocrinologists, and radiologists who are looking to optimize care of the patient through our culture of quality, focus on access, innovations in research, and educating the next generation of caregivers. By emphasizing innovative and quality patient care, research, and education, we provide excellence in our clinical programs, including the Center for Weight Management, featuring bariatric surgery and medical weight loss, GI cancer prevention, colon and rectal disorders, esophageal, liver, pancreas, and biliary diseases, and also motility disorders. Education and research is truly embedded in everything that we do. Our team of providers from multiple specialties work together to improve your health and well-being, teach the world about what we do best, translate cutting-edge research from lab to bedside, pursue quality initiatives to provide the very best care, discover innovations to transform your experience. Since 1982, our national breakthroughs have impacted treatment of digestive disease at the regional, national, and international levels. While we feel that digestive health at Virginia Mason Franciscan Health is very special, we have been honored to be awarded numerous accolades over the years, a reflection of the hard work of our providers and their dedication to their patients. Our presenters this evening are Dr. Joanna Law and Dr. Gautam Mankani. Dr. Joanna Law completed her residency and GI fellowship at the University of British Columbia, adding an MA in education from Stanford shortly after. She went on to complete a therapeutic endoscopy and clinical research fellowship at Johns Hopkins Hospital before joining Virginia Mason Franciscan Health in 2017. Dr. Gautam Mankani completed his medical degree at Ohio State University and following his residency at the University of Pittsburgh, completed a gastroenterology, hepatology, and nutrition fellowship at the Cleveland Clinic. Dr. Mankani joined Virginia Mason Franciscan Health in 2021 and currently serves as the medical director at the GI Cancer Prevention Program. We're so honored to have both Dr. Law and Dr. Mankani speaking this evening and look forward to engaging in discussion with them during our live Q&A session following their presentations.
Thank you so much, Jessica, for the lovely introduction, and thank you for the opportunity to be speaking tonight. And thank you everyone in the audience for joining us for this important conversation. As Jessica mentioned, my name is Dr. Law, and I'm a therapeutic gastroenterologist here at Virginia Mason Franciscan Health. And I'm also the director of the Hereditary Cancer Program here at Virginia Mason Franciscan Health. As Jessica mentioned, tonight we'd like to discuss understanding high-risk GI conditions. Could you be at risk? Dr. Mankani and I both have nothing to disclose, and I'll start the conversation about some common high-risk gastrointestinal conditions, including the stomach and the pancreas. Dr. Mankani will talk about the colon. We'll try to help you understand if you or your family is at risk for any of these conditions and learning about how we can help decrease your risk for developing any of these cancers. So what do we mean by high risk? There are certain factors that can increase one's risk for the development of cancers. There are things that we can change in our lifestyle or in our diet, what we call modifiable risk factors, such as exposures to certain toxins like cigarette smoking or certain foods. And then there are things that we can't change, or the non-modifiable factors, such as your gender or your sex, your age, your ethnicity, your family history, and more specifically, your DNA. We think about 10% of all cancers are related to a genetic mutation, so some change in your DNA that increases your risk for certain cancer syndromes. So understanding your risk. When we talk about understanding your risk, what we do is we start to balance your risks, the modifiable things, such as things we can change, and the non-modifiable things, And we compare it to the general population risk of developing certain types of cancer. If we feel that your non-modifiable and modifiable risks, so what is personal to you, is in excess or greater than what the general population would face for a certain type of cancer, we start to tailor specific types of screening and surveillance for that cancer based on your family history or your risk assessment. If you're less than the general population risk, then what we usually recommend is a general population approach or the average approach to screening for certain types of cancer. So hereditary cancers by organ type. The stomach is an organ that sits in the top of your abdomen right about midline. There are 5 parts of the stomach: the cardia, the fundus, the body, the antrum, and the pylorus. As everyone knows, it's basically where your food goes into for digestion. Every year, about 26,500 new cases of stomach cancer occur, and about one in the United States, accounting for about 1.5% of all new cancer diagnoses. When we talk about modifiable or changeable risk factors for stomach cancer, they include the presence of H. pylori infection, which is a common bacteria that has been found in the stomach and has been known over long-term exposure to be associated with stomach cancer. Diets, specifically those high in salted and preserved foods, grilled and processed meats, or diets low in fruit and vegetables can increase your risk for stomach cancer. Alcohol use, specifically 3 or more drinks a day, and any sort of tobacco use can all increase your risk for stomach cancer. So these are things that you as a patient can do to help decrease your risk by avoiding these risk factors for stomach cancer. With regards to inherited gastric cancer syndrome, the one that's most commonly known to cause stomach cancer is what we call the hereditary diffuse gastric cancer. This is an incredibly rare condition, but in people who do have it, they are associated with a more than 70% lifetime risk of developing stomach cancer. Also, women with this syndrome are at increased risk for developing lobular breast cancer. Other syndromes that can be associated that are inherited conditions for stomach cancer include Lynch syndrome, or HNPCC, and familial adenomatosis polyposis, which is another type of colorectal cancer syndrome, which is also increased slightly for developing stomach cancer, which Dr. Mancini will speak about later. The other risk factor from an inherited gastric cancer perspective is if you actually have a first-degree relative, so a parent or a sibling who has a history of stomach cancer, will also increase your own personal risk of stomach cancer, and that's important to disclose to your primary care or your gastroenterologist provider. With regards to pancreas, the pancreas is an organ that spans probably about the width of your body and lies just over your spine in the back of your in your abdomen. It works to make insulin, which helps with your diabetes or sugar management, and also makes enzymes that help digest food. This year, about 64,000 new cases of pancreas cancer will be diagnosed. And the pancreatic cancer accounts for 3% of all cancers and 7% of cancer deaths in the United States. Modifiable risk factors that are associated with pancreas cancer include any tobacco use, including cigarettes, cigars, and smokeless tobacco products, a BMI of 30 or more, type 2 diabetes, and we're not sure if the type 2 diabetes is basically a harbinger or like a red flag of about to develop pancreas cancer, or if there's some association with the actual damage from the pancreas resulting in type 2 diabetes and subsequently ongoing damage that results in pancreatic cancer. But there's definitely a relationship of people who have pancreatic cancer and type 2 diabetes. Chronic pancreatitis, which is this chronic insult to the pancreas with acute inflammatory changes, and certain workplace exposures to certain chemicals, especially in the dry cleaning and metalworking in refining industries. With regards to inherited pancreatic cancer syndromes, there's maybe 6 known mutations that we're aware of that we are consciously accounting for with regards to pancreatic cancer syndromes. The one that's the most common, surprisingly, are the ones that are associated with the breast cancer mutations, BRCA1 and BRCA2. BRCA1 and 2 are probably accounting for the majority of the inherited pancreatic cancer syndromes. And in these patients, they can present with family histories of breast cancer and pancreas cancer. And it's an important mutation to know about in your family because of this risk, but also because as we move forward, there's increasing targeted therapies towards these mutations that seem to have good and better response to therapy in the development of pancreas cancer. Another hereditary breast cancer gene, PALB2, is also associated with increased risk of pancreas cancer, as is the ATM gene mutation. And then there's also the familial atypical multiple mole melanoma, or FAMM syndrome, which is associated with a specific mutation. Dr. Mancini will talk about Lynch syndrome and MLH1 and MSH2 mutations, which are also seen to increase your risk for pancreas cancer, as are certain other pancreatic cancer and colon cancer syndromes, such as Peutz-Jeghers. Familial pancreatitis with a PRSS1 gene mutation is associated with an increased risk of pancreatic cancer, though there's some debate about whether or not this mutation really does increase your risk, as other evaluations and studies are showing that perhaps it's a combination of the mutation and smoking that are the combination, a two-hit phenomenon that really increases your risk of pancreas cancer. Understanding your risk is really important, and the Pancreatic Cancer Network, or PanCan website, is a wonderful resource to help you understand your risk. They have a really simple pancreatic cancer risk test that you can take online that's simple and easy to understand and actually actionable to help us understand what your risk might be from an inherited and also a general population risk. Thank you very much for your time at this for tonight. Dr. Mancini will now talk about colorectal cancer syndromes and some of the services we offer here at Virginia Mason with regards to hereditary cancer program and prevention.
Thank you, Dr. Law, for that talk. So this is the second lecture of our two-part series, and I'll be building on what Dr. Law talked about just earlier. So understanding high-risk GI conditions, could you be at risk? My name is Dr. Gautam Mankani, as we introduced before. I have no disclosures. Our agenda, again, building off what Dr. Law did, I'll be focusing on the highlighted parts. She talked about the stomach and the pancreas. We're going to focus on the colon today. And then I also want you to learn how we can help you decrease your risk of developing cancer. So, who are we looking at over here? We're looking at three personalities, three people you see on TV. What do they all have in common? Matthew Wright is a TV announcer in Britain. He comes from a family with Lynch syndrome. In the middle, we're looking at a blogger. He was diagnosed at colon cancer at the age of 14. He unfortunately passed away at the age of 20. And on the right, we're looking at Tim Hill, a famous pitcher with the San Diego Padres. He was diagnosed with Lynch syndrome. He was diagnosed with the colon cancer. He had half his colon removed, chemotherapy, and fortunately he's back playing the game. Now when you look at people and we look at their colonoscopies, we take images. What you're looking at are 8 images from 2 individuals. And I know you're not gastroenterologists, but looking at these pictures, we're looking at what look to be seemingly normal colons. You don't see any polyps. You don't see any masses. The inside lining, that mucosa layer, looks very healthy. But they're different. What if I told you the images on the top 4 are from one person with Lynch syndrome? So that individual may have up to a 75% risk of developing colon cancer. But not only that, knowing that they have Lynch syndrome, they have a high risk of developing endometrial cancer, also up to 70%, stomach cancer, ovarian cancer, cancer of the urinary tract, and a small bowel cancer. So both organs within your GI tract and organs outside of your GI tract. And the person on the bottom, when you compare those rates, They're just an average risk person who came to me for their screening colonoscopy at the age of 45. They don't have Lynch syndrome. They don't have any polyps. And their risk of cancer is so much lower. Their colorectal cancer risk is 4.5%. So both people, very different cancer risks, have very similar looking colons. It's helpful to know what the syndrome is and what someone has. Why does it matter? Well, as I said, it helps us understand the risk of cancer. It helps us understand the risk of cancer within the GI tract, understand the risk of cancer outside of the GI tract, and as equally important, it helps us identify members in the family who may also be at risk of having Lynch syndrome or whatever hereditary cancer syndrome we're talking about. And most importantly, once we know that, it helps us prevent those cancers. So what is a hereditary colorectal cancer? Dr. Law touched on this in her talk about hereditary cancers in general, but a hereditary colorectal cancer occurs due to a gene mutation that significantly increases a person's risk for cancer. The risk of cancer is based on the type of mutation that that person has. The gene mutation can come from a parent, and if you have that mutation, there's a 50% chance that you give it to a child, since your child's DNA comes from you and then from your partner. And since every single cell in your body has the exact same genetic code, every cell will have that mutation. And depending on what that mutation is, it will help us define what the cancer risk is in that part of the body. Are you at risk for stomach cancer, colon cancer, skin cancer, or some other sort of cancer? Now, I'm not going to quiz you. You're not going to get a test after this lecture, but there's a lot of hereditary colorectal cancer syndromes out there. And when we see a person for the first time who may be at risk, we start thinking, hey, what syndrome do you have? And because that helps us define, as I said on the earlier slide, what your cancer risks are going to be. So there's a long list of hereditary cancer syndromes out there. What are the general differences between the syndromes? So when you come to my clinic, I want to know what type of syndrome you have or what type of syndrome you may be at risk for. And again, I'm not asking you to learn all these syndromes, but I just want to kind of highlight what those differences are. They differ in the number of polyps that we may see in the colon. I am a gastroenterologist after all, and I will be doing a colonoscopy and counting the polyps. What types of polyps they have. So once we remove the polyp, we study them under a microscope. Our pathologist can see what exactly type of tissue the polyp is made of. Different syndromes have different types of polyps. What organs are affected? So within the GI tract and outside of the GI tract, and what the cancer risks are based on the type of syndrome that you have. And once we know that, it helps us come up with an endoscopy plan. It's not about should we be doing a colonoscopy or an upper endoscopy. It is when do we start and how often do we do it, because we know your cancer risks are so high. What are your surgery options? Are there ways we can reduce your cancer risk before you come to us with the cancer? What other screening tests do you need? Yes, we do care about colon cancer, but we care about all types of cancer. So are you at risk for thyroid cancer? Do we need to be doing thyroid ultrasounds? Are you at risk for uterine cancer or endometrial cancer? Do we need to get you connected with a gynecologist to do your screenings? Are there medications we can use to reduce your cancer risk or reduce the sizes of those polyps that we see so they're easier to take out? These are all things we think about. So going down each one of those categories, number of polyps. Here you're looking at 3 pictures from 3 different patients with 3 different hereditary colorectal cancer syndromes. On the left, you're looking at FAP, or familial adenomatous polyposis. These individuals have almost 100% risk of developing colon cancer. What you're seeing in the parentheses is what their colon cancer risk is. They have hundreds to thousands to hundreds to thousands of polyps. Their colon looks very different than someone with Lynch syndrome, similar to the images I showed you in the beginning. In Lynch syndrome, you may not have any polyps at all, or you may just have 1 or 2 polyps. That's the image in the middle. And on the right, we have Peutz-Jeghers syndrome. Peutz-Jeghers syndrome is one of our hamartomatous syndromes. The classification comes from the types of polyps that we see. In Peutz-Jeghers, you may have dozens of polyps or only a few polyps, and these polyps can grow very large in size. When we study them under a microscope, the pathology varies. So again, you're looking at 3 different pictures from 3 different syndromes and the 3 different types of polyps we see. I don't expect you to be a pathologist. I'm not a pathologist, but when our pathologists study these polyps under a microscope, they can tell us, hey, this is a type of polyp. This may be the type of cancer risk in the polyp. On the left, you're looking at a tubular adenoma. We see tubular adenomas in familial adenomatous polyposis. That was the picture with those thousands of polyps that you see. We also see this polyp in people who come for a screening colonoscopy, first colonoscopy at the age of 45 or 50. It's the most common type of polyp we see, actually. Then we have the Peutz-Jeghers polyp. It's very different than some of these other polyps. And you can see how under a microscope it looks very different than our tubular adenoma. Finally, we have our sessile serrated lesion. This is also a common polyp that we see on colonoscopy. These ones tend to be flat and hard to find, and that's why we really want you not to go on a tangent, to have really good bowel preps. So the types of polyps differ. Now, based on the type of syndrome you have, as I said, that same gene mutation is in every cell in your body. And the mutation helps us figure out what your cancer risks are. This is an individual with FAP, familial adenomatous polyposis. These are the people who have almost 100% risk of developing colon cancer, but they're at risk for other findings as well. Some cancer, some non-cancer findings. Osteomas, we see a lot of bone growths in any bony area of the body. CHIRPY. CHIRPY is an acronym, congenital hypertrophy of the retinal pigment epithelium, basically fancy for you see black spots on your retina. So many times ophthalmologists refer patients to us for having CHIRPY. This is a completely benign finding, having lots of teeth. Now getting to the cancers, at a very high risk for developing thyroid cancer, up to 17% over a lifetime. Kids with FAP can present to us with liver cancers, hepatoblastoma. We're seeing a lot of stomach cancers, duodenal cancers. Your duodenum is the first part of your small bowel. So up just after your stomach, you have your duodenum. That's why we do upper endoscopies in people with FAP. Colon cancer, and then adrenal adenomas. So again, here we're just talking about FAP, but every unique syndrome, every unique mutation has its own specific risk. And it's helpful to know that so we know how to screen for those cancers. So what are our management principles? How do we manage you? Well, depending on what you have, regardless of what you have, our goal is to decrease the incidence of cancer and then your mortality from cancer. We don't want you to get the cancer, and if you've gotten the cancer, we don't want you to die from that cancer. So how can we do that? Well, we have surgeries that we can do, medications that we can use, endoscopies. So everyone with a hereditary colorectal cancer syndrome may need some sort of upper endoscopy and colonoscopy. And again, the intervals depend on what mutations that we have. And it's not just about testing. We want to improve your quality of life. We know this is a stressful thing to have. We know there's a lot of anxiety that comes with having these conditions. Maybe the worry about having a child with this condition, and we want to be there for you to support you through any question that you may have or any help that you need. And we want to help you educate your family so we can identify at-risk people early before they come to us with the cancer. This is an individual with FAP. Again, that colon I showed you with the several polyps throughout the colon, who have a near 100% risk of colon cancer. Now, if we just focus on the colon and forget about it and forget about every organ, we may miss other cancers. In this individual with FAP, we did an upper endoscopy. And I know you may not be gastroenterologist, but what you're looking at is a stomach. And in this stomach, we're seeing lots and lots and lots of polyps. And in these polyps, we see large polyps and mounds of polyps. This patient actually was diagnosed with a stomach cancer. And so if we knew that they had FAP from the very beginning and we started their upper endoscopies, we could have removed these polyps along the way, maybe even done different sorts of tests to prevent that stomach cancer. So, are these syndromes that common? What if you're the first person in your family to have a colon cancer? Are you really going to be affected? Well, when we study all comers, so whether you're from a high-risk family or not, and we do genetic testing on them. With genetic testing, we can check for many genes, not just one gene, many of the high-risk cancer genes. We find that 10% of people may have a hereditary cancer syndrome. 10%. So 1 in 10 people coming with a colon cancer may have a hereditary cancer syndrome. That's very similar to what Dr. Law said, where she said about 10% of the population who comes with cancer has some sort of hereditary, may have a gene mutation associated with a hereditary cancer syndrome. Okay, that's all comers. What about people less than 50? Everyone here knows Chadwick Boseman. He was a star in Black Panther, amongst many other movies. He unfortunately died of colon cancer at a very young age, and an age less than 45. What's his risk of having a hereditary colorectal cancer syndrome? Well, in this study, the authors just looked at those people who are less than 50 years old, and they did genetic testing, again, looking for lots of genes, and assessed what's their risk of cancer. It was 16%. Pathogenic or lightly pathogenic means having a mutation that probably is associated with a cancer syndrome. So up to 16% of those younger than 50 may have a hereditary colorectal cancer syndrome. So many of us may be at risk unknowingly. What can we do to help you decrease that risk? Here at VMFH, we have the Gastrointestinal Cancer Prevention Program. And what we do is we offer a personalized consultation to basically learn about you and your family. We can review the modifiable risk factors that you may have that Dr. Law talked about. We help you see if there's non-modifiable risk factors. Do you have a gene mutation we should be worried about or test you for? We can offer genetic counseling, testing, and support you through it. And whether you have a mutation or not, we can also treat you. We can treat you with endoscopic surveillance, so we can do your colonoscopies, endoscopies, upper endoscopies, specialized therapeutic procedures such as endoscopic ultrasounds, get you on medications, and also get you connected with providers who we work with to screen for at-risk organs, such as our surgeons, our gynecologists, our thyroid doctors, you name it. We help you quarterback all your screening. We're a multidisciplinary team, so it's not just Dr. Law and I, but it's the whole hospital, the whole village helping to take care of you. That includes our primary care providers, surgeons, radiologists, pathologists, oncologists, dietitians, psychologists, social work providers, you name it. We're here to help you. And we know along your treatment paradigm, as you age, as you go through life, different questions may come up. When you're a baby, or if you have a baby, you're wondering, hey, did I pass that gene to my kid? Should I be testing my kid? At what age should I test my kid? When should I start colonoscopies? When should I get surgery? Do I need surgery? Okay, I had surgery. Do I need to do an upper endoscopy? Is there anything else I need to do? Are there medications I can take? We're here to help you, and we're here to help you along the way to answer all those questions. So with that, thank you.
So welcome back. Thank you, Dr. Mancini, for that wonderful talk. And you and I thought we'd just do some pre-recorded Q&A as kind of a bonus segment for our patients and for the audience out there, for those especially who could not make the live Q&A. So welcome back again, and I'm going to now share my screen, and we're going to just go over some questions and answers that Dr. Mancini and I thought were applicable or important that we've come across with our patients as well. All right. So the first question I frequently encounter, and I'm sure you do as well, is I saw an article in the New York Times about home DNA testing, or this came across my Instagram feed. What is this and should I do it? What are your thoughts, Dr.
Yeah,
McKay?
yeah, good question. And we do get this all the time. So thank you for your talk as well, Dr. Joanna Law, and too. So, you know, 20 years ago, DNA testing or gene testing was really a taboo topic, and it was not in reach to the consumer. It was there only for research purposes. If you wanted to look for a gene, it probably would cost $10,000. Now DNA testing has become really cheap, and there's a lot of companies in the space that are offering it. And so when you think of, they offer services like, what's your cancer risk? What's your ancestry? Who are you related to in this world? And you can do that for a few $100s. There's a lot that goes into testing. We need to look at the results, we need to validate the results, and we need to ensure that that they're accurate. There are a few labs that do that. I think that the home DNA testing kits are fun. I would do it for fun if you want to do it, but a lot of the stuff that they look for has not been validated. So I'll give you an example. There's many companies that test for BRCA mutations. The BRCA mutation is associated with breast cancer. If they find something that means that it's very high chance you have that mutation, and you really should see a clinician. But if they don't find anything, that doesn't necessarily mean you don't have a mutation, because it's more of a thing they're just doing for fun, and they're looking for some of the mutations, not all of the mutations. Dr. Law, what are your thoughts?
Yeah, I agree. I think it depends on what you're looking for. From us as, hereditary cancer specialists, we are very focused on what we're doing when we do DNA testing. The direct to consumer products, though, it's out there. Like you were saying, if you want to know what your ancestry is, you want to know if this person might be related to you or something like that. I think that there's some value in some of these home DNA testing kits. But if we're talking about specific syndromes or cancer diagnoses, or gene mutations associated with cancer, then I think that there's a difference in how we approach what we're doing versus what they're doing. It's kind of a needle in a haystack approach, right? With DNA testing, we know what we're doing, we have targeted things that we're looking for, whereas they're kind of like, well, we'll throw in a little bit of, your ancestry and your, what your ethnic makeup is, in addition to maybe we might find a BRCA mutation, but we're not looking for any other mutations because we're not set up for that. And again, I also endorse your concerns about the validation of these tests. We go through labs that undergo rigorous testing and are, basically monitored carefully for quality assurance. And so I do think that there's a difference in what we're offering, and in it difference to what the direct consumer testing is. All
Yeah,
right.
no, I absolutely agree. The one other thing I do want to add, the prices have become so similar, and I'm not trying to sell the testing that we offer, but the prices are the same as direct to consumer testing. So if you are a person who is at risk for a cancer syndrome, I really would come see a genetic counselor or someone who specializes in this area and figure out if you need testing or not. And if you do, go through that route.
So, if I took a genetic test and it was negative for colon cancer syndromes, so I saw you in consultation, you told me I don't have any of these colon cancer syndromes. Does this mean I never need to screen for colon cancer?
Absolutely not. So there is, everyone has a lifetime risk of developing cancer, and one of those cancers is colon cancer. We actually see it in about 4.5% of the population over their lifetime. And so what we're looking for on genetic testing is high risk genes, which give you a very high risk of cancer. So some of these genes give you 100% risk of cancer or a 50% risk of colon cancer. If you don't have a gene mutation that we test for, you are still at risk for cancer, and you still should comply by the screening guidelines. Dr. Lau, can you tell us a little bit about those guidelines?
Yeah, well, so going back to what we had talked about earlier in our presentations as well, it's all about balancing risk. So there's general population risk, and then there's things that we can put in the pot that increase your own personal risk. So even if you were negative for a colon cancer mutations, it doesn't mean that your general population risk has now gone to zero. So I do agree that what you were saying, the current guidelines do recommend that starting at the age of 45, if your average population risk, so if you don't have any personal or family risks that increase your general risk compared to the general population, we do recommend that some form of colon cancer screening should start at the age of 45, and you should reach out to your primary care providers to talk about what type of screening is the best type of screening for you. And there are different forms of screening, starting from as an uninvasive as the stool test, all the way to the gold standard, which is the optical colonoscopy.
Yeah, absolutely. And then I do want to add one last thing. Average risk, right? So average risk means that you do not have a brother, a sister, a mother, or a father with colon cancer, or a child with colon cancer. So that's the big thing. If you have a direct relative with colon cancer, you really should start. You should talk to your provider about when you should start screening. Okay, so Dr. Law, we know you're a therapeutic endoscopist, and you're absolutely in love with the pancreas. It's your favorite organ. And so this question is made basically for you. Doesn't everyone just die from pancreatic cancer? How can you prevent it?
So that's a great question. And over the years, we hear all these stories in the media about people who got their pancreas cancer, or someone who got pancreas cancer and died within a month or 2 months of their diagnosis. And that's where we're behind the 8 ball with pancreas cancer, is that we diagnose people much, much, much too late. By the time they present with their diagnosis of pancreas cancer, they tend to be metastatic and incurable. Our current survival, or 5-year survival for patients with pancreas cancer, has recently hit 12%, which is, victory for those of us in the pancreas cancer work as in the space, because for years and years, we were always under 10%, sitting at 9% 5-year survival. When we talk about pancreas cancer, what we talked about earlier in my talk was, about the fact that we have 6 identifiable syndromes, mutations that do increase your general population risk. So if we can identify these people early, in addition to people who have family histories of pancreas cancer, also talking about modifiable risks for pancreas cancer, our hope is that we can find people who are earlier in their diagnosis and hopefully earlier in their disease process, so that we can hopefully cure you and get these numbers in terms of survivability up. So in terms of preventing pancreas cancer, there are things we can do in terms of surveillance and screening, and also talking about modifiable risk factors. So it is not hopeless. There is a lot of work in this space that we are employing and engaging in, and talking to patients like you is really the biggest thing that we can do in terms of getting more information and learning more about pancreas cancer.
I have a quick question for you. I see a lot of patients who have a direct relative with pancreatic cancer. Is there anything they can be doing? So let's say you have a mom or a dad or a sibling with pancreatic cancer.
So that's a great question. And that goes back to our conversation of, well, did that first degree relative, did that parent, or, when were they diagnosed? Did they get genetic testing? Because like I said back in my talk, about 1 in 10 to 1 in 8 patients with pancreas cancer probably have a genetic mutation. So if your first degree relative did not get genetic testing in themselves, you actually qualify for genetic testing as a first degree relative of someone. So if your mom or dad got pancreas cancer and unfortunately passed away before they got genetic testing or never had the opportunity to get genetic testing, you actually qualify for genetic testing. And if we're able to identify a gene mutation in you, then we go down that gene mutation pathway. If we don't identify a gene mutation in you, though, I would have taken a full family history from you. And if there are other members in your family, you may qualify as what we call a high risk familial pancreatic cancer syndrome. So therefore, someone who does not have a gene mutation, but has a high family risk. So there's a burden in your family of pancreas cancer that puts you at higher risk.
Okay, great. Thanks.
Yeah. So this is a question for you because I know you love the colon and colon polyps is that my friend has a colonoscopy every 10 years. Why do I need to come more frequently than that?
Yes. So a couple questions ago, we were talking about average risk people, and average risk people can begin screening colonoscopies at the age of 45. As long as you're an average risk person and you don't have any polyps, which increase your risk for having colon cancer or are associated with colon cancer, then we keep you on a 10-year interval. But there's a lot that goes into determining what that interval should be. So if you are at a higher risk than what that average risk person is, we may start you at an earlier age and we may do it at more frequent intervals. Those intervals can be as short as 1 year, and they may extend all the way up to 10 years. You know, another big part of colonoscopy is we're trying to see your entire colon wall. And polyps can be very small, they can be very flat, they can be very hard to see. So the quality of your procedure also matters and goes into determining what interval we give you. So if you're an average risk person and you start at 45 and we see no polyps, but your bowel prep is not the best and we don't feel confident in the fact that we saw your entire colon, we may bring you back a lot sooner just so we can have another look. So quality matters, bowel preparation matters, and all that goes into determining what your interval should be.
Great. So therefore, it's important to talk to your endoscopist after your procedure to understand your risks, the quality of your colonoscopy and your bowel prep, and then your subsequent plan for follow-up and understanding that. So it's never a one and done. There's always some sort of personalized plan based on what we found in you. Is that correct?
Yeah, no, that's exactly correct.
Awesome.
Yep.
So then here's another question for you. I have a rare syndrome which has caused many cancers in my family. Do you just do colonoscopies or how else can you help?
Yeah, so the picture we're looking at on the left is basically these dark spots around the lips. And that's very typical of people who have Peutz-Jeghers syndrome. Peutz-Jeghers syndrome is one of our hereditary cancer syndromes due to a gene mutation. That gene mutation is in every part of your body, as we both said in our talks, and that increases their risk for multiple cancers, not just colon cancer. And so we don't just do colonoscopies. We are gastroenterologists. We do love our procedures, but our goal is to prevent cancer in you. And so we screen and survey you for all the cancers that you may be at risk for. Dr. Law, can you tell us a little bit about our GI program for cancer prevention and how exactly that works and what we do?
Yeah, so, when you do have a mutation, as we've kind of alluded to before, it doesn't affect just your GI tract. Sometimes it can affect other organs and is in your DNA. And so therefore, like Dr. McKinney was saying, as from a program perspective, what we want to offer you is the ability to give you peace of mind that you are being cared for as best as possible from a multi-system perspective. So as a whole person from head to toe for whatever cancer you're at risk for. Again, so it's personalized and it's also based on evidence-based guidelines that help direct us in terms of how often and what we're checking for in you. And that also not only depends on your gene mutation if you have one, but also depends on your family history. So in some people, they may have a known gene mutation that's associated with breast cancer, but they also happen to have family history that's really quite worrisome for, say, stomach cancer as well. And their breast cancer mutation doesn't happen to be associated with stomach cancer, but we will offer all of that for you because we take a full comprehensive history. We're a multidisciplinary team. So we work with, as Dr. Mankini had explained, multiple specialists all around the hospital and your primary care and you to help you coordinate and prevent, and ideally, if we do have a cancer, detect it early in you and provide then the segue and also the treatment options that are available for you with your known mutation.
Thank you. Yeah, we want to be a one-stop shop for both you and your family. And we realize that many questions will come along the way as you go through life. And we want to help you to navigate those experiences. So Dr. Law, thank you so much for doing this. Everyone, thanks for listening. We really look forward to learning more from you. And so if you have any questions, please feel free to reach out to our center or your provider, and we'll be more than happy to help. Thank you.
Thank you.